Hello and welcome to another Pype pod. Today we're going to continue the patient examination theme and we're going to look at cranial nerve assessment. As most of you know, we've pretty much all learnt the cranial nerves in the past, and it can be a pretty confronting topic, very difficult to really get your head around, and there's a lot of literature, theories, tests that can be done. So what I hope to do today is give you an overview and give you a suggestion of how to do a relatively simple yet still pretty comprehensive test of the cranial nerves. So starting off, I highly recommend, if you have trouble following along, write this list down. Just pause the video and write down this list, so then when we talk about it and I mention cranial nerve 2 or 5 or 7 or whatever it is, you'll be able to quickly look back at your sheet and see which one I'm actually talking about. That way you'll have a little bit better association with what I'm talking about, and it can help. So let's kick right into it, and we'll start right at the top, number 1, okay, which is the olfactory, and that's all about your sense of smell. Now before we go on, I shouldn't have to say, but just in case anyone doesn't realise, when we talk about cranial nerves, there's 2 branches to every cranial nerve. Okay, I know, lucky you're sitting down. So every test that we do, we need to do bilaterally. So in the case of olfactory nerve, we need to check the air movement in both nostrils, okay, because that generally gives us an idea of if sensories like smell can actually get to the nasal bulbs, to get to the olfactory nerves to be interpreted as odour. Okay, because if they can't breathe in through their nose, then it may not be an olfactory problem, it may actually be a obstructive or fraction-based problem. Once you distinguish that they can actually breathe through both sides of their nostrils, then we move into smell. So coffee is a great one because everybody loves coffee, and if they don't, then they should. But if you don't have coffee, anything with a distinctive odour to it, okay, your chewing gums or your lollies or whatever it is from your rat pack, you can test. Initially you put it close to the nostril, just one nostril at a time, get them to breathe in. Once they've established the smell, move it away 10 centimetres to have a sniff to see if they can smell it again. Okay, the reason we do that is they may have slight swelling around the actual olfactory nerve, which means they've got a reduction in their sense of smell as opposed to a loss. So if they can smell it close, but not 10 centimetres away, it may be an indication of early onset of swelling, lesions, what have you. Okay, so that's cranial nerve 1. Nice and simple. Moving on, we go to the optic. Okay, cranial nerve 2, and it's tested by itself because there's a lot to test in cranial nerve 2. So we start with our visual acuity. Now if the person wears glasses, okay, we're not testing necessarily 20/20 or things like that, we're literally seeing if they can see the way they normally would see. So we get them to put their glasses on and we do the visual acuity. We use the Snellen chart, either on the board or you can get really good apps these days on your phone. So you can do it pretty much in the field or anywhere. And you test the visual acuity. And you note down, as we always have, over 6, over 20, depending on what chart you're using, and then you go from there. Visual fields they're not very difficult to test, visual fields, but it's quite complicated to actually know what's going on if there is a problem within visual fields. So first of all, we'll discuss how to conduct a visual field. It's simply done by you standing directly in front of the patient. Okay, you staring at their nose, they're staring at your nose. And then you essentially move your arms right out as far as they can, and you bring them in towards your face and wiggle your fingers. The idea is if your visual field is not affected, when you see your finger wiggle, they should be able to see the same thing. Okay, so we go from above, left and right, and then we come from below. Now not directly below, but pretty much on a 45-degree angle up towards their nose. And we note any difference basically, which means if you see the right hand coming in from the direct right, and you see it wiggling, but the patient hasn't seen it wiggling until much later, then it denotes that they have a right-sided visual field problem. Now the way the visual fields works internally, so when you're looking at the actual optic nerve, so the optic nerve supplies each eye. So you do have one optic nerve going to each eye. But then it meets in the middle and then it branches off. So it actually has 2 branches for each nerve off from there. And it goes all the way around to the occipital region of your brain in order for interpretation. Now you can get lots of data on which one of these small nerves, especially from the crossover to the occipital region, and if any one of those is damaged, you will get different patterns of visual acuity loss. But the easiest way to think about it is if you have complete right or left-sided visual loss, then the lesion or the problem is generally close to the eye. If you have complete lateral loss, so both left and right lateral loss, then you can pretty much assume that the problem is right at that crossover. Okay, now from there it gets more complicated because you'll have varying degrees of loss on the left and right side, depending on which one of those branches from the crossover to the occipital region is damaged. As you probably picked up, if you have any sort of visual field loss, then the person needs to get evacuated and they need to get further investigation. Whilst that's common sense and all, it's very interesting to know, bottom line is you see a problem, you refer it on straight away. When we deal with pupil response, okay, so we're actually testing pupillary response to light, you're actually testing the cranial nerve too, so the optic nerve, so sensing the light, but then the motor response, coming back to the actual cilia muscles that control the pupil, is cranial nerve 3, your ocular motor. So doing your pupil response will actually test 2 and 3 at the same time. Okay, now if you have a lesion on a certain aspect of the optic nerve, what you will find is that your pupils may still react, but they're not equal in their reaction. Which means if you have a left-sided lesion, you shine it in the left, you may get a response. When you shine it in the right, you will get a stronger response. Okay, as opposed to if the lesion's further back, and then you'll have basically sluggish movements each side. Okay, so that's your pupillary response, and that's your test for your optic nerve. Okay, so just remember visual acuity, visual fields, and then pupil response. Now, moving on to extraocular movement. Okay, this is testing cranial nerves 3, 4, and 6. Yeah, I know it's quite annoying. 3, 4, and 5 would have been nice, but it's got to do with where the actual cranial nerves branch out from the brain in the way that they're numbered. So 3, 4, and 6 is for extraocular movement. Now, you'll see on the screen a list of muscles that are involved in different movements. Okay, so we've got your lateral, medial, superior, and inferior rectus muscle, and then your inferior and superior oblique muscles. Now, if you look at the bottom right, you'll see the direction of eye movements and which muscles are responsible for those particular movements. Now, when we're dealing with cranial nerves, the main thing really to remember is your lateral rectus is your cranial nerve 6. Okay, so your abducens cranial nerve is responsible for your lateral rectus. And as you can see, your lateral rectus is responsible for your extreme left and your extreme right movement of eyes. Okay, so when you're testing your lateral rectus, you see if they physically can go left and right, and you look for signs of nystagmus, which means on the extreme left or right, the eye will bounce. Okay, if you have that, you may have some conductivity problem within the nerve, or you may have some inflammatory or reductory chemical on board, which makes you have this nystagmus. And we'll talk a little bit more about nystagmus later on when we get down to the other cranial nerves. Now, your trochlear nerve is responsible for down and inward movement of the eyes. Okay, so very limited sort of move. If you're trying to go cross-eyed by looking at your nose, that is your trochlear nerve. That is what it does. When we're testing it, we need to make sure that we actually test that one as well. So looking at the movements of the eyes and looking at the way we generally test the eye movement, okay, we can sort of see that the old H that we usually do misses some of the cranial nerves. Okay, so the H is really good if you just want to test your ocular motor. Okay, if you just want to test your ocular motor, you do the H. Because when you think about it, with the H, you're not going to the extreme left and right with the lateral rectus, and you're not going cross-eyed with the superior oblique muscles. Okay, so your H can be fine for your cranial nerve 3, ocular motor. But in order to test the other two, you need to go extreme left, extreme right, and then the cross-eyed as well. And what we're looking for is unequal movement of the eyes. Okay, so whether there's a delay whether there's stepping, if you will, so the sort of like you're playing a game that's buffering while the eye's moving along and it just sort of bounces behind the other a little bit slow. So anything that doesn't look normal. So that's your extra ocular movement. So remember, we do the H, that's normal, that's standard. Don't forget your abducens and your trochlear nerve, extreme left and right, and cross-eyed. Now when we look at cranial nerve 5 and 7, yes, it may sound like we're jumping around, but it'll all make sense soon, I promise. 5 and 7, your trigeminal and your facial nerve. So when we look at the different functions of those two nerves, okay, your trigeminal nerve has a large sensory function, the ophthalmic, maxillary, and mandibular. The whole side of your face, with 3 different branches, is sensory for your trigeminal nerve. Your motor responses, or your motor capabilities with your trigeminal nerve, has got to do with clenching your teeth and it's moving your jaw side to side. They're not up and down, but side to side. Okay, that's what your trigeminal does. Now your facial nerve, well, that's fully responsible for your motor control of your entire face. Obviously you've got 2, so left and right. Okay, so that's sort of why we put them together, because they've both got to do with your sensory and your motor control of your face and jaw. So when we're testing, it makes sense that we test the trigeminal by getting the patient to close their eyes, and then we lightly touch the 3 branches of their face. So ophthalmic above their eyebrow, maxillary along their zygomatic essentially, and mandibular, which obviously along the angle of their jaw. So you touch there and you see if they have equal sensation in each one of those places, and also equal sensation left and right. When we move on to the motor function, okay, remember when you go back to anatomy physiology of nerves, a block or a lesion in a certain area can cut off sensory or can cut off motor based on the different areas in which they're placed within the nerve themselves. So we test sensory and we test motor. So we get the person to clench down hard on their teeth and then go through motions of grinding their teeth left to right. Whilst they're doing that, we actually palpate their temporal regions and their mandibular area. And what we're feeling is symmetry of muscle contraction. You're actually feeling for that tension of muscle contraction as they're going through the motions of grinding teeth and bearing down hard and clenching their teeth. So that's your trigeminal tests. When you move on to your facial test, it's really a series of activities that you ask the patient to do. Initially look at their face and look for signs of symmetry. Make sure there's no drooping. Now sometimes when the person's standing there and not actually moving their face, it can be quite difficult to see if there is asymmetry. So that's why we get them to wrinkle their forehead. So look up and really wrinkle their forehead. We see if they can close their eyes against your soft resistance. Okay, and you can get them to smile, puff their cheeks out, and then you can even test their cheeks by pressing softly on their cheeks while they're puffed to see if it actually puffs up. Okay. Now there is another test that you can do, but it's often not needed. You can test their sense of taste in anterior aspect of the tongue. Okay, like 2/3 of the tongue at the front is controlled by the facial nerve itself. It's not, like I said, it's not often done, but technically it is something you can test with the facial nerve. Now if you want to test both of them, say you're really pressed for time for some reason, you don't want to do a thorough examination, then you can do your corneal reflex, which is you get a cotton tip, you pull a small bit of cotton out so it's only a couple of threads, and then you touch their cornea with it. Now obviously that's going to be irritating. The cranial nerve 5, your trigeminal, is going to feel the actual cotton tip, and cranial nerve 7, the facial, is going to do something about it by actually closing the eyes. Okay, so that's the relationship between 5 and 7, and a nice easy test that you can do in order to do them both at once and see the relationship. Cranial nerve 8, okay, your vestibulocochlear, also known as your acoustic nerve. That's responsible for your hearing and your equilibrium, balance, the sense of where you are in space. Okay, so 2 different tests. Okay, so we always do the hearing because it has a pretty big function within the vestibulocochlear nerve. So we start with a hearing test. Now when you're doing a hearing test, obviously you don't have to do a audiometry. You can start by just rubbing your fingers together on the left and right side, or whispering something like a question or getting them to repeat it. And then ascertaining if these simple tests is positive or negative. So if they can hear you rub the fingers, or if they can answer your question that you whisper, then you don't have to go any further with your hearing test. Okay, if you do have hearing loss, then you could, just refer them for further testing, or you can do the further testing yourself. Okay, now when we're dealing with hearing problems, especially when we're dealing with the vestibulocochlear nerve, we need to know if it's a conductive or a sensorineural problem. So conductively denotes that there's a blockage, okay, a huge bunch of wax, foreign body, or something blocking the auditory canal. And then your sensorineural is the actual vestibulocochlear nerve. You can look in the ear, okay, but to really test if it's conductive or sensory, then we do what's known as a Weber test. Okay, so you need a tuning fork. Okay, love tuning forks. They're an amazing tool. Should be in every RAP. And you know what? You should carry one in your pack too. They're very versatile. So if you can, ideally get one that is at the 512 hertz. Okay, you don't want to use the 128. It's not appropriate for this. So get the 512 hertz tuning fork. The way to use it is you squeeze the ends together, you tip your fingers and thumb, and then flick it. From there, you place the tuning fork on what could essentially be called like the mid section of their head. Okay, so you put the tuning fork on their head, midline of their skull, and you get them to listen. Now, let's say you have a hearing problem on the left. So when you're doing the rubbing of the fingers and the whispering, you've denoted that they have a hearing problem on the left-hand side. So when you do the Weber's test and you put it midline of their skull, if it's a conductive problem, then it's actually going to sound louder on the left-hand side because the vibrations are passing through a semi-solid mass within the person's ear. Therefore, it's sounding louder because it's traveling through the actual skull and then vibrating on these semi-solids. So it'll be louder on the left-hand side. But if it's a sensorineural problem, then consistently it will be louder on the right-hand side. Bare minimum, start with the rubbing and the whispering. If you want to go further, it involves tuning forks and a little bit more understanding of how sound travels. When it moves to the other job of the vestibulocochlear, moving into the cochlear aspect of the cranial nerve, then we do a equilibrium test. Now this is only done if the person has a complaint of dizziness, okay, so a new onset of dizziness. Then we do these tests, okay, so the Hypoglossal maneuver test, okay, if you haven't heard of it before, then I highly recommend that you look it up. Now, if you're not comfortable conducting this test, then don't. Okay, hand it over as a problem that you've noted. So the idea of this Hypoglossal maneuvers test is a way to determine whether or not the vestibulocochlear could have what's known as a peripheral lesion or a central lesion within the actual cranial nerve. So the way it's done, now this is for interest only, okay, and the first time you do it, I suggest you do it with medical officers and people that do it as well, so they can take you through the technique a little bit better than a talk over. A purely interest takes. The way that you do it is you sit the person on a bed, okay, on a bench, doesn't really matter, but you sit them up and you turn their head to the left or the right. Doesn't really matter which way. You turn it to the extreme left so they're looking over their left shoulder. From there you support their head and you move them down so they're lying down and their head is actually just a little bit below the level of the bed. So that's the technique. You move them down. Now, you don't have to throw the people down so then they will get dizzy. You just have to lie them down relatively steady rate below the bed, and what you're looking for is you're looking for nystagmus and you're asking the person about vertigo. Generally speaking, if you have peripheral lesions, your nystagmus and your vertigo will be slightly delayed, like a couple of seconds. You'll be slightly delayed and it will last about a minute or so. Okay? And then if you sit the person up, they can actually adapt. So you sit the person up, have the person look to the left and lie them down again, they can actually have lesser symptoms, so they take longer to kick in or they don't last as long, and that's denotion of a peripheral lesion. Okay, if you have a central lesion, then they can pretty much hit straight away. and you'll get horizontal or rotatory nystagmus, and the person will complain of vertigo. So that's general rule of thumb what you're looking for. You need to test both sides, so once you've done the left and you're looking for signs of adaptation if they have vertigo, then you do the right. The main reason you do that, because eventually as you lie them down, one ear is going to be obviously down and the other ear is going to be up. The ear that is down is going to put a lot of pressure on the posterior semicircular canals, whereas the one that's up is going to put increased pressure on the anterior semicircular canals within the ear. So when you swap them, you can test all aspects of the semicircular canals in both ears. Okay, so that's the idea. It's why you need to go bilaterally in order to test the entire cochlea. Okay, like I said, quite advanced, purely out of interest. I suggest you practice it with your GP, with your doctors before, so then you get a better understanding. Moving on, cranial nerve 9 and 10, so glossopharyngeal and vagus. Now these two are tested together. Okay, the reason they're tested together is 9, your glossopharyngeal, it's all about your sensory aspects to the pharynx. Now your vagus nerve, now we all know the vagus nerve does a lot. Okay, a lot of very important things, especially when we're dealing with emergency medicine. Okay, but in this case, to test it, it's responsible for the motor control of your pharynx muscles, so like your gag reflex. So that's why we test them together. First thing you do, as you should always do, is you listen to the person talk. If they're hoarse or whispering, having a loss of control of their pharynx, then it's something to take note of. If they've articulated any swallowing problems, it's also something to take note of. Now some people will give them actually a drink of water and watch them swallow. Okay, so that's a test that you can do. Okay, but if you want to test them both at once relatively quickly, then you can simply look in the person's mouth, and first of all you're looking for the position of the uvula itself. Okay, is it off to one side or is it in the middle? Okay, that's the first thing you note for. Then you get the person to say the old traditional R. You're looking for the lift of the pharynx, make sure it's symmetrical, make sure it lowers together, make sure it raises together, and that's about it. From there we get your tongue depressor, and you test the gag reflex of the pharynx. So either side of the uvula, you touch the left, they will gag. When they gag, the actual pharynx will rise and then lower. So obviously just as they gag, you remove the tongue depressor, and then you test the other side. So it tests both because the cranial nerve 9 is sensing your tongue depressor, pressing on the pharynx, and your cranial nerve 10 is doing something about it by raising the pharynx to get away from it and actually gagging. Okay, so that's the test for those two. Okay, cranial nerve 12. No, I haven't missed one. We're just doing cranial nerve 12 first because we're already playing with the mouth. Okay, so cranial nerve 12, the hypoglossal, is responsible for tongue movement. So this is a pretty simple test. You get them to poke their tongue out and make sure the tongue is midline. Okay, so not leaning to the left or leaning to the right. From there you can test tongue strength. Again, this is more of an advanced test to make sure that they may have subtle changes within the hypoglossal nerve. So you get the patient to push the tongue against their cheek, okay, as hard as they can, and then you sort of fight against their cheek by pushing it in. See if they've got equal strength left and right. When you're looking in someone's mouth, okay, I just mentioned you look at the uvula, and now you look at the tongue deviation. Thing to note, just to keep in the back of your mind, if you have a left lesion or a left problem of the cranial nerve, then your uvula will actually go to the right hand side, as opposed to if you have a left cranial nerve 12 problem, then your tongue will actually deviate to the left. Okay, so keep that in the back of your mind. Okay, it's absolutely not exactly vital for you to know, but it can be quite interesting for you to know. And the last one, cranial nerve 11, okay, your accessory. This is a very simple test. You're testing resisted movements of your sternocleidomastoid and accessory muscles. Okay, so you simply get the person to turn to the extreme left under resistance and then turn to the right under resistance. Resistance can be simply your hand on their face. Don't really fight them because you will have sternocleidomastoid and spinal pain doing so. Okay, so just a little bit of resistance. See if it's equal strength left and right. and then get them to shrug their shoulders under your resistance as well. So put your hand on their shoulders, get them to shrug, looking for bilateral strength or bilateral weakness. Okay, or unilateral weakness. Alright, so that's final test, your accessory nerve. Because we've gone through a lot, this is one of the ones that you may need to listen to a couple of times, practice a few times on someone, and then after a while it will literally get routine. Okay, you can practice doing an entire cranial nerve assessment. You don't always need to, but just as a way for you to really practice those tests. So the order, just to quickly go over them again, just for repetition of knowledge, is we start with cranial nerve 1 and we test their sense of smell. Then cranial nerve 2 with visual acuity and visual fields. We test cranial nerve 2 and 3 when we do Perla. Cranial nerve 3, 4 and 6 is all about extraocular movement. Okay, so you do your H movements, getting them to keep their head still, but then you remember to do your extreme right and your extreme left and get them to go cross-eyed. We move on to cranial nerve 5 and we test bilateral face sensation and jaw movement. We finish with a corneal reflex that will test cranial nerve 5 and cranial nerve 7. We move on to cranial nerve 7 with looking at facial expressions and bilateral facial movements. Okay, by getting them to raise their eyebrows, smile, puff their cheeks. We test cranial nerve 8, the vestibulocochlear nerve, by simply testing the hearing with whispering or rubbing of the fingers. If there is a problem, we can move on to advanced testing with the tuning fork. And also, if there is equilibrium problem, they complain of dizziness, like recent onset, then you can do your help hike maneuvers if comfortable. We move on to cranial nerve 9 and 10, Glossopharyngeal and vagus, by looking in the mouth as they say ah and testing bilateral gag reflex. We get the patient to poke their tongue out, which will test cranial nerve 12, and we get them to press against their cheeks for bilateral strength. Finally, we finish with cranial nerve 11 as we test their accessory movements under resistance. And that is a cranial nerve test. So I hope you got something out of this. Like I said, listen to it, practice it, make it part of your routine during sick parade or during patient examination, and try to get an understanding of the cranial nerves and how they work and how you can look for signs and symptoms to note if there's a problem. Until next time, take care.